Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. They will be very useful to fourth year students in oral exam as well as theory exam, and also it will be useful in internship and while you are doing your private practice, because good number of all these lectures whatever I have uploaded you will come across in your everyday practice. Yes, material whatever I have gathered is mainly from YouTube's, Google, from slideshare.com, etc. So today we'll be discussing on one of the very interesting topic, that is clubbing, that is clubbing of finger or clubbing of nail. So you come across very commonly in your everyday practice, and if you pick up, you try to identify what is the cause of clubbing. First you have to identify there is clubbing or not, and then you have to try to identify the etiology. So we'll be discussing in the definition, etiology, pathophysiology, clinical features, how you examine the person, investigations, differential diagnosis. There is nothing like treatment for treatment or complication of clubbing, but mainly treatment is of the underlying cause and complication is because of underlying etiology of clubbing. So basic definition of clubbing, it is defined as a selective bulbous enlargement of the distal segment of the finger and toes due to proliferation of connective tissue. There is also another way of description. It is mainly on the dorsal surface. It is painless, soft tissue swelling in the terminal phalanx, and because of that there is an enlargement and increase in the convexity of the nail. This is another way of defining. There is still another slide also, will be showing you that slide. Sorry, there are other names which are being given to this. Now because of deposition of this proliferation of connective tissue, there is increased sponginess of the soft tissue at the nail bed. This is also called digital hypocratism or pectorodactyly, Hippocratic finger, drumstick finger, watch glass nail, etc. These are the different name given to what we call is a clubbing of finger. So it is also described as a bulbous uniform swelling of the soft tissue of the terminal phalanx of a digit with a subsequent loss of normal angle between nail and nail bed. Basically, clubbing is a physical sign characterized by bulbous enlargement of the end of one or more finger or toes. Same definition, that is, it is a bulbal swelling of a terminal part of the finger and the toes with an increase in the soft tissue mass, an increase in AP and transverse diameter of the nail due to proliferation of subungual connective tissue, whichever way you define. Either you define this way or you define this way. Both are same, meaning there is a bulbous uniform swelling of the terminal part of the finger or toes, and that will result into sponginess of the nail bed, loss of angle between nail and nail bed. This is described as clubbing. So selective bulbous enlargement of the digital segment due to increase in the soft tissue. So it is basically a clinical sign involving bulbous or bulging enlargement of the distal end of the finger or toes. And this is because of the increased growth of connective tissue and that results in reduced angulation of a nail with a respected nail plate. And there is one sign called as a Sembroth sign we'll be discussing in detail. And here there will be loss of Sembroth window, or we call diamond shaped window between the two when you put your two fingers together, there is a gap seen here. You can see a light through this. It is a diamond shape. When this is lost, we call that a Semberoth sign, or also called Semberoth window sign, and that is a classical. So in a clubbing, you will get that window is absent. Here you can see clearly that window, and that window, loss of Semberoth window, is called Semberoth window sign or Semberoth sign, or some person also called as only window sign. So in a clubbing, there is a loss of Semberoth window, and that is called Semberoth window sign. As far as classification or types is concerned, we can divide one way: generalized and localized. Generalized can be hereditary or acquired. Generalized means all 10 fingers and 10 toes. Localized can be only in one finger or one toe. Very classically seen in AV malformation, congenital AV malformation, and occasionally in case of a localized gigantism. It is also classified according to the severity, like mild, moderate, and severe, or grade 1 to 4, and sometimes some person utilizes grade 1 to grade 5. Etiology wise, congenital and acquired, and also you can put one etiology as idiopathy. Then clinically, clubbing may be with cyanosis or without cyanosis, and if you add one more symptom in that, clubbing with cyanosis with dyspnea, or clubbing without cyanosis without dyspnea, and according to the onset, acute or chronic. First description of this clubbing was described about 2500 years ago by Hippocrates, and that's why it was labeled as Hippocratic finger. Now, depending upon the different stages, this is the stages which are being classified: stage 1, stage 2, stage 3, stage 4. We'll be also showing you again that in detail. This is a normal angle of nail to nail bed, and that is called as a Kurth angle, which is normally less than 160 or not more than 160. But when that angle is increased because of convexity of the nail, then it becomes more than 180. Then it is described as Lovibond sign, and this angle what you measure is called Lovibond angle. Now in stage 1, there is a normal appearance and angle, normal appearance of nail and angle, but there is an increased fluctuation of nail bed, or we call sponginess of the nail bed. There is a special technique by which you try to elicit that. We are having figures for that. We have got slides. When that Lovibond's angle get lost or it becomes more than 180, then it is called stage 2. So loss of angle between the nail and nail bed means instead of acute, it is becoming obtuse, more than 180 degree. So it becomes more than 180 degree, we call Lovibond sign. And when there is an increased curvature of the nail, that is called parrot-beak appearance, and that becomes stage 3, like this, parrot-beak appearance. It will be much more curved. We have got lot of photographs. And stage 4 is expansion of terminal phalanx, drumstick appearance, and also there is hypertrophy of the bone because of periosteal deposition. It is called hypertrophic osteoarthropathy. So that is one way of classifying according to the stages. Etiology wise, congenital and acquired, and one more we put is idiopathic. In congenital, one classical example we also call hereditary or familial. You can come across cyanotic congenital heart disease, or we call right to left shunt. This will be congenital heart disease group where person is born with cyanosis. So they will have a cyanosis and generalized clubbing. Hereditary is by and large, or there is another word utilized for hereditary, is familial. That is bilateral drumstick clubbing, and it is also generalized. But AV malformation and focal gigantism will be usually focal, involving one thumb or one finger or one toe, etc. While in idiopathic we cannot come to the nearmost diagnosis, then we label that as idiopathic. Among acquired, it can be respiratory group, cardiovascular, alimentary, and others. Out of all this, the respiratory comes topmost on the list. It is accounting for almost 70 to 80% of the causes. Combined with cardiovascular, it will be almost accounting for more than 80% of the causes. And 10 to 15% of the group is idiopathic. So, another way of putting an etiology in generalize, it will be congenital, or we call hereditary or familial. And among acquired, respiratory, cardiovascular, alimentary system, idiopathic, and miscellaneous. So, as far as generalized is concerned, congenital group is there, and among acquired group, respiratory, cardiovascular, alimentary, idiopathic, and miscellaneous will be generalized. While focal is only AV malformation and gigantism, and will be putting you in unilateral groups. There is one group, unilateral group, say as for example, bronchogenic carcinoma like Pancoast tumor, aneurysm of subclavian arteries, etc. We'll be discussing that. If you want to remember by mnemonics, clubbing, so C for congenital cyanotic heart disease, cystic fibrosis, Crohn's disease, then cholangitic cirrhosis, L for lung abscess, lipoid pneumonia, atrial myxoma, U for ulcerative colitis, B for bronchiectasis, bronchogenic carcinoma, B for biliary cirrhosis and blue heart, or we call cyanotic congenital heart disease, I for infective endocarditis and idiopathic pulmonary fibrosis, N for neoplasm of lung, liver, esophagus, large bowel, small bowel, etc. and G for Graves' disease or thyroid acropathy. There is also one we always forget is pregnancy. During pregnancy also you can develop clubbing. Not always, but you can. There is another way of remembering: C for cardiac causes, R for lung, U for ulcerative colitis, B for biliary cirrhosis, and another B for what we call is a bronchiectasis and bronchogenic carcinoma. These two are second B. Then I for intestinal causes, N for normal or idiopathic, and G for genetic or familial. There will be other condition also which will be added, say like in a cardiac congenital cyanotic heart disease, infective endocarditis, Eisenmenger syndrome, primary pulmonary hypertension, and very rarely atrial myxoma. In lung we already mentioned lot of causes: lung abscess, empyema, bronchiectasis. These are called suppurative lung disease. Bronchogenic carcinoma comes topmost on the list, and this particular etiology accounts for nearly 70 to 80% of the groups. Ulcerative colitis as well as a Crohn's disease also comes quite common. Then biliary cirrhosis, hepatocellular failure. Among I intestinal groups, inflammatory bowel disease, which will include ulcerative colitis as well as Crohn's disease, also malabsorption syndrome. So these are the big groups. So you can see here 70% is thoracic, 5 to 10% is congenital or familial, and idiopathic will be accounting for another big group. So you can see here 80% of the cases are respiratory, 10 to 15% are cardiovascular, so it will be almost 90 to 95%, and rest will be either hereditary or idiopathic. Indirectly, cardiovascular and respiratory will be accounting for nearly 90 to 95%, and familial or idiopathic will be accounting for 5 to 10%. So that will be most common. And among respiratory, bronchiectasis, lung abscess, bronchogenic carcinoma, empyema comes topmost on the list. So this will be topmost on the list. Always look for those causes. So among respiratory, chronic hypoxia like cystic fibrosis, interstitial lung disease, sarcoidosis, etc. Suppurative lung disease, bronchiectasis, lung abscess, empyema. And among malignancy, bronchogenic carcinoma, mesothelioma. So that will be the three big groups. Cardiac, congenital cyanotic heart disease, infective endocarditis. And you can add cor pulmonale, AV shunts, AV aneurysms, and chronic congestive heart failure because of chronic hypoxia. Not common, but may develop cyanosis. Among liver, primary biliary cirrhosis, amoebic liver abscess, amyloidosis. GI tract, IBD, inflammatory bowel disease, which will have ulcerative colitis, Crohn's disease, and even chronic amoebic dysentery, and even celiac disease is being added. And there is one more group among GI tract. You can have cirrhosis of liver, hepatoma also. Then hypertrophic osteoarthropathy, which will be a painful clubbing and may be associated with fever and joint effusion. There are endocrine groups like thyrotoxicosis, hyperparathyroidism. Then during pregnancy, alcohol, chronic myeloid leukemia, renal carcinoma, certain hemoglobinopathies, acromegaly, toxins like mercury and arsenic, and don't forget hereditary and idiopathic. Yes, we have already mentioned all this: idiopathic, genetic, thyrotoxicosis, acromegaly. It is also called thyrotoxic or Graves' disease. We call thyrotoxic acropathy. Then asbestosis, sarcoidosis, amoebic liver abscess. There is also called POEMS, that is polyarthropathy, O for organomegaly, E for endocrinopathy, M for monoclonal gammopathy, and S for skin changes. Together it is called POEM syndrome. So rare condition, but once in a while. And among occupation, it is described as a jackhammer clubbing or jackhammer because of constant using of hammer, traumatic injury, and you develop. Ideally, it is not clubbing, but it is described as jackhammer toe or finger. You can come across unilateral clubbing, which is classical in case of Pancoast tumor, subclavian or innominate artery aneurysm, axillary artery aneurysm, AV fistula of brachial vessels, and also in case of cervical rib. Only single digit clubbing, very commonly seen in upper limb because of traumatic injury. Just now we have uttered that jackhammer toe or it should be jackhammer thumb or finger. Also you get in a gout, particularly chronic sarcoidosis, and once in a while hereditary because of AV malformations. Very commonly only in upper limb in case of heroin addicts due to chronic obstructive phlebitis, unilateral clubbing is seen. Also in aneurysm of major extremities artery, particularly say like subclavian artery or axillary artery or AV fistula in a brachial vessels, etc. You can develop that. And once in a while AV fistula, if it gets infected, that AV fistula grafts get infected, again you can have a unilateral clubbing. Clubbing of the toes is associated with infected abdominal aortic aneurysm and in case of a patent ductus arteriosus, particularly with reversal of the shunt, in that you will have cyanosis plus clubbing. Some of the clubbing is reversible. As soon as you treat that basic condition, clubbing may reverse back. Say, like example, lung abscess, empyema, and infective endocarditis. Clubbing can be painful, and when you try to palpate, it may be painful, and that can be very common in infective endocarditis, bronchogenic carcinoma, and lung abscess. So painful reversible clubbing, you can combine together. You call that as a painful reversible clubbing. So that will be quite common in infective endocarditis, bronchogenic carcinoma, lung abscess, empyema. There is one also called as differential clubbing. If clubbing is seen in a lower limb but not in the upper limb, classical with a PDA with Eisenmenger, or we call PDA with reversal of the shunt, infected abdominal aortic aneurysm, coarctation of abdominal aorta. Similar way, you can get only in upper limb. We already mentioned here. You can get in upper limb in case of a heroin addicts where you don't have a clubbing in lower limb, or in case of aneurysm of subclavian, or if AV fistula which is being created and that gets infected. So infected AV fistulas and infected arterial grafts which has been utilized in upper limb. There is one more term which is being utilized, is acute clubbing. Very rapidly which develops within 10 to 14 days, and classical example is lung abscess and empyema, and may also be acute in case of infective endocarditis. So these three will be acute clubbing, reversible clubbing, and painful clubbing. So there is something called as a pseudo clubbing, where ideally it is not clubbing but it looks like in case of acromegaly, scleroderma, and hyperparathyroidism. So this is nail plate, and this is a subcutaneous tissue below the nail bed. This is in the nail bed, and this is a skin fold. This is a skin fold. So as the deposition gets here, this collagen tissue is deposited here due to proliferation of subungual connective tissue. This is a subungual connective tissue, and there is an interstitial edema. There is a dilatation of arterioles and capillaries. So this nail will be convex, will become convex, and this angle, which is normally less than 160 degree, will become now obtuse. So that angle gets obliterated. It is the word utilized is obliterated, and it is called Lovibond's angle. And when that becomes more than 180, it is called Lovibond's sign. There are a lot of theories and lot of mechanism which was being described. One was anoxia or hypoxia due to opening of a deep AV fistulas because of toxic substance. Neurogenic pathophysiology like vagus nerve getting involved, metabolic like in case of a thyrotoxicosis, increased growth hormone, example in acromegaly, or because of shunts, that is we call AV shunts, or because of circulation of ferritin, reduced ferritin, and when you can't identify the cause, idiopathic, and when it was genetic, it was called hereditary. There are also four proposed mechanisms which has been well established, like vasodilator circulations, tissue hypoxia, neurocirculatory reflex, and genetic factors. There is another way of putting all this pathogenesis, means there is increased production of a vascular endothelial growth factor, which is a platelet derived factor, and that is stimulated by hypoxia. And secondary to hypoxia, you get increased production of vascular endothelial growth factor, short form we call VEGF, which is derived from platelet and also produced in a certain malignancy, and condition that affects the circulation like AV fistulas, aneurysms, etc. And this particular endothelial growth factor will induce vascular hyperplasia, edema, fibroblast proliferation, and even osteoblast proliferation, which will end up finally to what we call as a hypertrophic osteoarthropathy at peripheral levels in the nails. There is also a neural mechanism which is being involved through vagus system is also being proposed, and this platelet derived growth factor stimulates the growth, increases the vascular permeability. There is a monocyte and neutrophil chemotaxis that leads to proliferation of vascular smooth muscle, proliferation of fibroblast, and results in clubbing. In genetic and hereditary, exact mechanism is still not known. So anoxic hypothesis, humoral hypothesis, reduced ferritin level, vagal theory. In anoxic hypoxemia, development of AV fistulas, overgrowth of soft tissue. Because of humoral, there is a release of certain endocrine hormones like growth hormone, bradykinin, parathormone, estrogen, etc., which also gives rise to dilatation of vessels in finger and hypertrophy of terminal phalanges. Reduced ferritin will result into dilatation of AV at arteriovenous anastomosis, and again that will result into dilatation of vessels and fingers. And vagal theory also suggests that there is a dilatation and it will finally end up into hypertrophy. And whenever you do a vagus nerve ablation, clubbing improves. So this was one of the theory which was put forward. So there is a platelet derived theory which suggests that because of a chronic inflammation, there is a secondary to inflammation, acute phase reactant, platelet derived growth factors, and that leads to proliferation. Because of chronic hypoxia, there is a vasodilatation, and because of increased blood supply, there is again release of platelet factor, platelet growth factor, we call endothelial growth factors, and that will lead to soft tissue proliferation and clubbing. In case of acromegaly, growth factor, and in others, you will have a soft tissue growth. Chronic hypoxia will lead to increased level of estrogens, and that will also lead to vasodilatation and proliferation of soft tissue. Now, depending upon, we have already mentioned in types or terminology, that is, it can be generalized or localized. Depending upon the severity, mild, moderate, and severe, or we classify them into grade 1 to grade 4, or there is another way of classifying is grade 1 to grade 5. Depending upon the etiology, congenital, acquired, and idiopathic. And then clinical finding wise, clubbing may be with cyanosis or without cyanosis, or may be also associated with symptom like dyspnea or no dyspnea. So depending upon that, you can approach. So now whenever you want to first identify clubbing, there are certain things which are being observed. So while you are examining, you can find out painless or painful clubbing, whether it is bilateral or unilateral, whether it is acute or chronic. So try to identify those, whether it is localized or generalized, and which fingers are involved, which toes are involved, and look for different signs. We'll be going through all those signs. So try to put them into, by good history, examination, put them into generalized or localized group. Try to identify the grade. By a good history, congenital, acquired, or idiopathic. And look for the other associated findings like cyanosis and associated symptoms like dyspnea. They will help you. Because if a person has got dyspnea and cyanosis, it is more in favor of cardiovascular and respiratory groups. So while approaching to the clubbing, we call how you examine. So first history, physical examination, general examination, and then examine respiratory, cardiovascular, and alimentary system. Those are the three common systems which can produce clubbing. From a good history, congenital and acquired can be easily identified. By examining general examination, you should look for cyanosis present or absent, whether it is central or peripheral. And from a good history, chronic hypoxia signs are present or not, and from examination finding. And by systemic examination, whether respiratory system is involved, cardiovascular is involved, or alimentary system. And if you don't get anything, we put them into idiopathic groups. And by a good physical examination and general examination, you divide them into localized or generalized. And we have already mentioned the etiology, which are localized, unilateral, upper limb more involved, lower limb more involved, differential clubbing, etc. And then you try to identify the severity and put them into grade 1 to 4, or you can utilize grade 1 to 5. By and large, the most common grade which are being utilized is 1 to 4. So first thing is always look tangentially at the nail bed angle, whether the angle, lower bound angle is more than 180 degree or not. We call that as a lower bound sign. You can look for Sembrot sign. You can palpate the finger by a special method and look for fluctuation. So in a grade 1, fluctuation will be present. In grade 2, lower bound sign will be seen. In grade 3, you will have a loss of lower bound angle and lower bound sign with parrot-beak appearance. And in grade 4, you will have parrot-beak appearance along with drumstick clubbing, and you might have even hypertrophic osteoarthropathy. And by a good history, we always put them into congenital and acquired, localized and generalized. And by looking at cyanosis, it is with cyanosis or without cyanosis. So now we'll be going through one by one. So always look for nail bed fluctuation, nail bed to nail angle, curvature, and amount of soft tissue. So how you look for? So this particular was first described as Hippocrates. So it is also described as Hippocratic finger or Hippocratic sign. Normal person will have a normal onychodermal angle, which is always less than 160 degree. This is also described as a lower bound angle. So that is an angle between proximal nail fold. This is a proximal nail fold and nail bed. This is nail bed. So nail plate and proximal nail fold. This angle. When this becomes convex, this angle will become more than 160 degree, that is more than 180 degree. And when it becomes more than 180 degree, it is described as lower bound sign. And to look at that particular angle, you will have to look tangentially, and this is described as a profile sign. So bring the patient finger at the level of your eyes, that is tangentially, and look tangentially, and look for the lower bound angles. If lower bound angle is 180 degree or more, then it is described as clubbing. So more than 180 degree is described as clubbing. So 180 degree or more than 180 degree of lower bound angle. This is how you look for tangential. And this is the angle. So if this angle becomes more, now we have got lot of photographs. You can see here this is a normal angle. This is less than 160. This is more than 180. So this is a lower bound sign. Never look from the top. No doubt this is clearly a clubbing, but this is not the technique to identify the lower bound angle. So always look tangentially. So when you look tangentially, and if the angle is more than 180 degree, this is more than 180 degree. If we draw the straight line here, it is more than 180 degree. So this is a lower bound sign. So lower bound angle is more than 180 degree. Here you can see that it is straight. So it is less than 180 degree. So then it is not clubbing. So look tangentially, this will be the angle less than 180 degree. Basically it is less than 160 degree. So Lowy bond angle or Lowy bond sine more than 180 degree or 180 degree or more than 180 degree, it is considered as clubbing. Normal is less than 160. And that normal angle is also called as a Kurth angle. Kurth angle. So Lowy bond angle more than 180 degree is clubbing, and that is described as Lowy bond sine. Now what we call is a fluctuation, this is for stage 1 or we call grade 1. So floating sine or fluctuation test. So floating nail sine is described. So you have to hold the finger. This is with a middle finger, you hold it, and the tip of the finger is held by 2 thumbs, and with the index finger you try to fluctuate, and if the fluctuation is present on the side as well as on the top, then you describe that as a floating nail sine, and that is grade 1 sine, grade 1. So even if you put your thumb and finger and try to press this, and if you get that the spongy feeling, that is also one of the technique, but best method is this technology, that is called floating nail sine. You can see that you hold with middle finger and with thumb you hold the tip and then try to palpate with these 2 fingers, that is with index finger, and try to elicit the fluctuation, and if the fluctuation is present, we call that the floating sine is positive. Then when you put the 2 finger, that is 2 thumb together like this, it is shown here, or you can utilize the index finger, there is a gap here, you can call this as a Semroth window, and if this Semroth window is lost, it is called Semroth sine or Semroth window sine, or also only as a window sine. So this is called Semroth sine or a window sine or Semroth window sine. So normally Semroth window is seen clearly. If it is obliterated or it is not seen, it is clubbing, and then it is described as a Semroth sine or a window sine or Semroth window sine. And you can see clearly here, you can see a small gap here, it is a diamond shape, and here because of clubbing that is absent. You can see again here, this is normal gap, here it is absent, so this is clubbing. It is called Semroth window sine or Semroth window test. So that is typical. You can see a gap here, and when you look at the nail bed angle more than 180 degree, it is called Lowy bond sine. This is fluctuation test. This is Lowy bond angle more than 180 degree, it is Lowy bond sine. This is Semroth window, and when it is absent, it is called Semroth window test or Semroth window sine or Semroth sine or window sine. So Semroth window sine or window sine or only Semroth sine, whichever word you want to utilize. So this is fluctuation test. This is Semroth sine or Semroth window, it is absent, so Semroth sine or Semroth window sine or window sine, etc. And this is Lowy bond angle less than 160 degree normal, more than 180 degree or 180 degree or more than that, clubbing, and that is given a name Lowy bond sine. Classical Semroth sine, window is seen, here it is absent, so this is clubbing. Again you can see window is seen clearly, it is absent, so this is Semroth sine or Semroth window sine or only window sine, whatever word. Then there is another one thing which is being commonly utilized is phalangeal depth ratio. Normally no one makes an attempt to by these 3 easily, fluctuation, Lowy bone angles and Sembrot sign is enough to make the diagnosis of clubbing. But you can utilize, this is the distal phalangeal depth. So distal phalangeal depth, and this is interphalangeal depth, and you try to calculate the ratio. So if the ratio becomes reverse, it is clubbing. Normally IPD is always bigger than DPD. So if DPD becomes bigger than IPD, it will be reverse ratio, and then it is in favor of clubbing. Very rarely person utilizes this. That is also called digital index, means sum of all the phalangeal depth ratio for all the 10 fingers. If that digital index of all the 10 fingers is 10.2 or higher, then it is indicative of clubbing. Very rarely person utilizes this. And although the phalangeal depth ratio of 1 or greater in any finger is also suggestive of clubbing. So if it is 1 or more than 1, it is suggestive of clubbing. And when you add all those, if it is 10 or more than 10.2, it will be suggestive of clubbing. We already mentioned before, stage 1 fluctuation, stage 2 fluctuation will be present with Lowy bone sign, stage 3 parrot beak appearance or drumstick appearance, and stage 4 parrot beak appearance, drumstick appearance with hypertrophic osteoarthropathy. That is stage 4. So very easy. Fluctuation sign, grade 1. Nail bed gets obliterated or we call Lowy bone's angle positive, grade 2. Parrot beak appearance, drumstick appearance, grade 3. And with that drumstick appearance, if there is associated with hypertrophic osteoarthropathy, grade 4. Some person utilizes that. This is grade 1. This is absence of Lowy bone angle, grade 2. Clear cut drumstick clubbing, grade 3. And if you get an X-ray, and if X-ray shows hypertrophic osteoarthropathy, then it will be grade 4. Grade 5, some people utilizes that. Will be showing you one. So hypertrophic osteoarthropathy is grade 4. So this will be drumstick clubbing. So this can be grade 3 or grade 4. But for differentiating grade 4, you will have to have X-ray. So that will be there. So there is another way of remembering: S for softening, O for obliteration of angle, P for parrot beak appearance, and H for hypertrophy. It is better to remember fluctuation, Lowy bone sign, parrot beak appearance or drumstick clubbing, and hypertrophic osteoarthropathy. If it is because of lung, then it is called hypertrophic pulmonary osteoarthropathy, HPOA. Otherwise, always we use HOA, hypertrophic osteoarthropathy. As far as stage 5, when you utilize stage 5, so stage 1 fluctuation, stage 2 Lowy bone angle, stage 3 parrot beak appearance, stage 4 drumstick appearance, and stage 5 hypertrophic osteoarthropathy. Some person also utilizes early clubbing, that is stage 1, middle, that is stage 2, and stage 3, 4, 5 is severe clubbing. And here F for fluctuation, L for Lowy bone angle, I for increased convexity or parrot beak appearance, D for drumstick clubbing, and S for signy changes in nail and hypertrophic osteoarthropathy. This is called FLITS, whichever way you want to remember. So this is grade 1 to grade 5. In grade 5, you separate that is hypertrophic osteoarthropathy, and grade 3 is parrot beak appearance, drumstick appearance is grade 4, and grade 5 is hypertrophic osteoarthropathy. So this is typical grade 1 fluctuation test positive. Grade 2 will be Sembrot sign, and we can call Lovibond's angle being positive. So Lovibond angles is obliterated, or Lovibond sign, that will be grade 2. This is Lovibond angle has become obtuse or more than 180 degree. This is grade 2. Clear cut. Parrot beak appearance, grade 3. By and large, when we use grade 4 category, so grade 3 will include parrot beak appearance and drumstick clubbing. And grade 4 will be periosteal thickening, hypertrophic periosteal thickening. So it is hypertrophic osteoarthropathy. So hypertrophic osteoarthropathy, which is a combination of 3 things: clubbing plus arthritis plus subperiosteal new bone formation. Short form we call HOA. And when it is secondary due to pulmonary disorders like bronchogenic carcinoma or mesothelioma, it is called hypertrophic pulmonary osteoarthropathy. And you will see a bone deposition, periosteal deposition, subperiosteal deposition in lower end of radius, ulna, and also in the lower limb, tibia and fibula. So that will be very characteristic. So you can see this is periosteal deposition of a bone. This is hypertrophic osteoarthropathy. If it is due to lung, hypertrophic pulmonary osteoarthropathy. And if it is not due to lung, it is hypertrophic osteoarthropathy only. It is also labeled as primary hypertrophic osteoarthropathy or periosteosis. And this will happen, a digital changes typically begins at or about the time of puberty. And this is described as a primary hypertrophic osteoarthropathy, where you will have a thickening being demonstrable on an X-ray examination. But it is not due to what we call as malignancy of lung like mesothelioma or because of bronchogenic carcinoma. But it is an autosomal dominant trait, and that is primary. But when it is because of malignancy, we call that as hypertrophic pulmonary osteoarthropathy. So when you say HPOA, that is hypertrophic pulmonary osteoarthropathy, it is due to bronchogenic carcinoma or because of mesothelioma. Classical drumstick clubbing. This is classical, this is parrot beak appearance, this is clubbing with cyanosis. Again you can see parrot beak appearance with almost nearly drumstick clubbing. This is typical drumstick clubbing with parrot beak appearance, so you can put them into grade 3. And if you want grade 4 differentiation, you have to have an X-ray. So this is a parrot beak appearance with a drumstick, and here you can see even there is mild cyanosis. So this is a parrot beak appearance with drumstick clubbing. This is because of repeated trauma, we call it a pseudo clubbing, or also you come across in jackhammer toe or finger. Actually jackhammer thumb or finger. You can come across also in case of acromegaly. And clubbing or hook nail deformities. You can get this. This is pseudo clubbing in yellow nail syndrome. You will have a typical this fungal infections. And once in a while you can come across a local clubbing because of infected abdominal aneurysm only in lower limb. You don't come across in upper limb. This you can call as a differential clubbing also. You can utilize that word. Yes, by history we always can rule out congenital and acquired. And congenital are always drumstick clubbing, they are generalized. If it is right from the birth and if it is involving one toe or one finger, or one thumb. Very common it is because of AV malformation or focal gigantism. And if it is acquired, which is generalized, then by and large it is congenital or acquired, and among acquired it will be cardiovascular, respiratory or alimentary, most common. And if none of these three holds true, then it is idiopathic. Drumstick clubbing with cyanosis since birth will be always because of cyanotic congenital heart disease. And if it is acquired are usually mild, very rarely they will be drumstick, and usually they are slow onset, and they will be classically seen in a cardiovascular, respiratory, alimentary, and also in case of a idiopathic. So history, examination and investigations will help you to identify what is the exact etiology of clubbing. If there is a cyanosis with clubbing, always suspect cardiovascular and respiratory. Among cardiovascular, mainly congenital cyanotic heart disease. That will be the most common. And also once in a while, in case of a chronic congestive heart failure, Eisenmenger syndrome, and also you can come across in case of a chronic hypoxia, which can be because of chronic congestive heart failure. While in case of an acute left ventricular failure, acute central cyanosis because of acute pulmonary embolism, there is an acute hypoxia, you will not develop clubbing. It will be more common with a chronic hypoxia. So in a lung disease, COPD, interstitial pulmonary fibrosis, interstitial lung disease, those group will develop clubbing rather than pneumonia, pulmonary embolism developing clubbing. And in a lung, mainly we have already discussed before, suppurative lung disease, malignancy, and what we call as hypoxic condition, chronic hypoxic condition because of a lung pathology will have clubbing. Clubbing without cyanosis will be very classically in case of genetic or we call familial, GI tract causes, malignancy, infective endocarditis, idiopathic group, AV malformation, gigantism. All this will be clubbing without cyanosis. While clubbing with cyanosis will be respiratory and cardiovascular group. Always look for those groups. There is one word called as acro-osteolysis. This particular is a pachydermal changes of extremities and face, where you get typical all these signs of a scalp, nasal folds, clubbing, prominence of a folds in a scalp, and there is a deep folds and furrow of the face. This will be very typical. It is described as a pachydermal changes because of acro-osteolysis, and these are the changes in the scalp. And there is one syndrome, Torrent-Solent-Gold syndrome, very funny name. You come across quite frequently in a we call as Graves' disease, we call thyroid acropathy. You get changes in the lower limb, more common, and you get clubbing and exophthalmos. Just opposite of clubbing is koilonychia. So do remember, sometime in oral they can ask you, what is opposite of clubbing? That is koilonychia, which is classical in case of iron deficiency anemia. Very rarely idiopathic or familial. You can come across on onycholysis when a person uses overuse of solvent, particularly when you paint your nail and for removing that nail paint, so you overuse the solvents repeatedly, you can develop koilonychia. And absolutely rare in case of thyrotoxicosis, you can develop koilonychia. Very, very rare. As far as treatment is concerned, clubbing may be a sign, but depending upon the etiology, you will have to give the treatment depending upon the etiology. We already mentioned there are some clubbing which are reversible, particularly bronchiectasis, lung abscess, empyema, infective endocarditis. They may reverse back. They are by and large painful, good number of time acute, but they may be reversible. So always identify the cause and treat the basic cause. So I end my lecture here. If you feel this lecture is helpful to you, press button like. You can give a comment so I can improve in my video series. I would love to have your comments, suggestions, etc. And if you like this, do not forget to subscribe. You can also share with your friends. At the end of this lecture, I thank you for taking out time. I know that your time is valuable and I appreciate this for spending some of the time with me. See you in the next lecture. Hope this lecture will be helpful to you.